Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
I'm Spencer King. I'm Editor-in-Chief of JACC, Cardiovascular Interventions, and we have with us today Dr. Michael Linkoff, who is the Vice Chair of the Department of Cardiovascular Medicine at the Cleveland Clinic. And Mike's got a fascinating paper coming up in an issue of JACC, Cardiovascular Interventions, that we're going to ask him about. Mike, the Acuity trial was an interesting one, a lot of fascinating information, but you've discovered some things relative to the use of clopidogrel and bivalirudin. I want you to tell us what you learned.
The initial analysis, primary analysis of the Acuity trial had suggested that in patients who were not pretreated with clopidogrel before they underwent coronary intervention, there appeared to be a higher event rate of ischemic events with bivalirudin-treated patients. The problem with that sort of top-end analysis was that it included patients who had been quite delayed in their treatment of clopidogrel after the coronary intervention. We did a more detailed analysis of patients who underwent PCI, over 7,000 patients in the Acuity trial, and looked at different time periods of clopidogrel pretreatment. And the primary finding was that in patients who were pre-treated with clopidogrel before the procedure or who received their clopidogrel up to 30 minutes after the end of the PCI procedure, so models clinical practice, that there was equivalent event rates in the heparin plus 2B3A arm as compared to the bivalirudin monotherapy arm. That the excessive rates of events occurred only in patients who were treated with their clopidogrel, their first dose, more than 30 minutes after, or a minority of patients who actually did not get clopidogrel at all despite receiving a PCI.
This seems to fly in the face a little bit of what we know about the time course of clopidogrel effectiveness in the metabolite taking at least a couple of hours to be effective. What's the explanation for this protective effect?
Well, we don't mean to interpret that there isn't a beneficial effect of pretreatment, because many prior trials have suggested that and shown it fairly clearly. But what this seems to suggest is that benefit is the same in bivalirudin as it is in heparin plus 2B3A. So if possible, pretreatment, but if pretreatment isn't possible, one can expect similar outcomes in the two arms. And the potential mechanisms for that would include the fact that, unlike heparin, bivalirudin doesn't activate platelets. So you're not kind of behind the eight ball to start with if you're giving bivalirudin, that you need that extra degree of platelet inhibition. And bivalirudin also inhibits one pathway of platelet activation, that is the thrombin-mediated pathway. So it does have some degree of antiplatelet effect. So those different factors combined probably account for the fact that bivalirudin resulted in similar outcomes as heparin plus 2B3A, even if patients had not been pre-treated but were treated promptly thereafter.
Sure. So what would you recommend to people who have patients, they have not been on any pre-treatment, perhaps an acute patient, and they are undergoing PCI, and for one reason or another have not received any antiplatelet therapy, maybe they've been on aspirin. How should we choose with this information which patients should get 2B3A and which patients may not need it and can go with the bivalirudin?
Well, I think that this makes us fairly confident that one can use bivalirudin in that setting. And so then the question is, how would you choose under any setting? In other words, I think you can take the thienopyridine pretreatment out of the equation, out of the consideration, unless for some reason one doesn't expect to treat after the procedure for a while, in which case 2B3A probably is superior. But between Acuity and also other studies such as Horizons and even higher acuity patients and replace in lower risk patients, I think it's fairly clear now consistently that bivalirudin has equivalent outcomes in terms of the ischemic events, and in all of these patients, one trial after another has the 40 to 50% reduction in bleeding, which one could expect. So that to me has shifted the balance, I think, in many cases to favoring use of bivalirudin.
So I guess there's no, the one message we could certainly take away is that avoiding the 2B3A, avoiding the clopidogrel and aspirin after is not acceptable. So everyone has to be on that. Would you agree?
I would certainly agree.
Yeah. Okay.
And I also don't want this to be interpreted as there's no value to pretreatment, because I think, again, we've had a number of studies that have said pretreatment is good, but if one can't do that, one can still choose your anticoagulant.
Well, I hope everybody will be digging into your paper in JACC Cardiovascular Interventions in the upcoming issue, and we enjoyed speaking with you very much. Thanks a lot, Mike.
Thank you for your interest.
a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.